Okay, hi everybody, hi PIH community around the world. Thanks for tuning in again to Facebook Live. Today is World AIDS Day, and I'm very delighted to be sitting here I'm Joya Mukherjee, I'm the Chief Medical Officer of Partners in Health. Very delighted to be sitting here with my good friend, Dr. Sarah Stulak, who's Deputy Chief Medical Officer. We're going to be talking about AIDS today, since it's World AIDS Day. We're going to be talking about our own personal experiences of Partners in Health around the world. And of course, as two Americans, we're really representing a very large team of Haitians and Rwandans, Liberians, Basutu, Malawians, Sierra Leoneans, who are really fighting around the world for AIDS treatment access, for health equity, for social justice. And World AIDS Day came into being many, many years ago because AIDS was at that time a fatal disease universally. It was highly stigmatized, as many people know. And so the idea of coming together in remembrance of people we had lost, of the struggle for justice and fairness and against stigma and discrimination was really the root of World AIDS Day many years ago. And now we get to celebrate. We get to celebrate all of the great achievements that have occurred because of the fantastic movement of AIDS activists around the world, from Partners in Health to ACT UP to the Treatment Action Campaign, and TASO and organizations throughout the world who came together to really fight for treatment access and succeeded. And today there are 17 million people around the world who are on AIDS treatment, many of them treated for free. So what we're going to do today is just reflect a little bit on Partners in Health contribution to that movement and where we are today and where we're going to be going forward. Before we start with that, Sarah, would you like to say a few words?
Just also wanted to say hello. I'm glad to be here, and just, from my past 11 years of working with Partners in Health, it's just, I do feel both remembering the people we've lost today, but also, as Joya said, really celebrating how much success we've had. When I think back to being in Africa just before 2005, when the medications really became more available widely, and seeing, feeling just the grief and the injustice of watching people die, watching children die, specifically in Lesotho where I was working, and feeling so frustrated and angry at not being able to bring medications to children who needed the meds, even though they were in the country. And then even just a few months later, when I joined Partners in Health and moved to Rwanda, and not only had access to the medicines, but was really driven, and I guess just as a pediatrician, remembering how different it felt to feel helpless and watch people die versus a few months later feel completely empowered to not only bring the medicines but also do everything else that PIH does, which included, giving those kids food, sending them to school, giving them community health workers. And so for me, that was kind of what made me feel like this not only works, but it's the right way to do it, and we've got to do it this way, and we've got to do it in more places. So I that being 10 or 11 years ago, and then just seeing how far we've even come from there is awesome.
It's amazing. It's really amazing. So, Partners in Health, as many of you who've tuned into Facebook Live know, we're not an AIDS organization. We're a social justice organization that believes that healthcare is a basic right, and that believes that healthcare and health is rooted in what we call the social forces, the social determinants, which are food and water, housing, jobs, lack of discrimination, access to education. And so when we stumbled upon AIDS in Haiti, we were a very small organization that was working with a community in Conge of people who had been displaced by a hydroelectric dam. And trying to work together with that community to see what it was that was ailing people and how we could help. And what we saw at the time with Paul Farmer, Ophelia Dahl, Père Lafontaine, later Maxie Raymondville, Ferney Leond, and many of the community members, is that AIDS was just one of many things that people suffered from. Tuberculosis, malaria, many other things, broken legs, cancer. And so we built a small hospital, and when AIDS therapy, first AIDS testing, became possible, of course, we tested people with the symptoms. And some of those tests that were done in the mid-'80s at Zami La Santé in Central Haiti were among the only free AIDS tests in the world that were given to poor people. Once antiretroviral medicines were shown to have effect in preventing mother-to-child transmission, we right away gave those medicines to women in 1995 to prevent their children from getting infected. And what we found, not surprisingly, was when the medicines were there, many more women came forward for a test. So we linked testing, prevention messages, and treatment from the very beginning and didn't say you either do prevention or treatment. We brought them together with community education and community participation. And then, in 1995 and 96, it was clear that this cocktail, this 3 drugs, AIDS drugs, if used together, could transform HIV from a death sentence. Everyone in the world nearly who had it died in 2 to 5 years, to a lifelong illness that was manageable and that people could live well. And we saw this happening around the world, and here in the United States even we called it the Lazarus effect. Many of us, myself at the time, I was a physician already, and saw people very huge movement of remarkable people in the United States. Many of them still are friends, people like Greg Gonsalves, Mark Harrington, Eric Sawyer, who were fighting for these new drugs to be developed. And what was so remarkable is when they got those drugs, they kept fighting. And they kept fighting, and they said, it's not just about me, it's about women in Soweto. It's about sex workers in Bangkok. And this global movement of solidarity came forth to say it can't just be about Americans who have access to medicines, health insurance, hospitals. It has to be for everyone. And that sort of international solidarity was totally remarkable, unprecedented. And I think when we see what we're facing around the world, more international solidarity has to be part of the solution for all of the things that ail us. So at Partners in Health, because we were treating literally a handful of patients, that small story of finding poor people in rural Haiti, many of them were our own friends and staff member, and treating them became, and we published it in a paper, and while that paper was not well loved by the scientific community, it was loved by activists because they said, that's an example of something we could do anywhere. It's being done in a very difficult environment. And, it gave people like our dear Alex Coutinho, who now runs our project in Rwanda, hope in Uganda. Many people even came from different countries to see this little pilot in the rural community of Conch, which even today isn't even on the map of Haiti. It was a squatter settlement. So that example put us as part of this movement. We made so many wonderful friends around the world, like Dr. Binagwaho, the former Minister of Health for Rwanda, Peter Mugenyi from Uganda, many of these leaders, because so many people were trying to do this for their own communities, for themselves, for their own people. And so we started working on this. Jeff Sachs, the economist, came to Haiti. He costed out the model of the HIV Equity Initiative. That was our initiative to provide drugs for people who needed it in Haiti. And he said to Kofi Annan, he was an advisor, and he said, that can be done. They're doing it in Haiti. This is what it would cost. If the drugs were not part of this equation, this is what the staffing would cost. This is what the food people need, the social support Sarah was talking about. And Kofi Annan used that information to call for the creation of the Global Fund. We were also asked by the Bush administration to think this through with them. Tony Fauci called Paul Farmer, and that information went into the creation of the President Emergency Plan for AIDS Relief, or PEPFAR. And these two funds, which now have put somewhere in the neighborhood of $50 billion into AIDS, was what allowed Partners in Health to expand around Haiti. And we made this very clear decision that we're not going to expand in a charity hospital. We're going to take these drugs and we're going to put them in the public sector and revitalize the public sector, but not just for AIDS, we're gonna put in essential drugs. We're gonna pay community health workers. We're gonna hire staff. And when we saw this revitalization, these clinics just suddenly having hundreds of people, and we, by the way, we found HIV, we found TB, we did all the things we needed to do, but we also provided healthcare as a matter of basic human rights and justice. That's when other countries started inviting us. And Rwanda, the government of Rwanda said, that's what we want. We want a charity, an NGO like Partners in Health that's going to help us take care of our own people in the public setting. Not just have an HIV program over here vertically, just doing HIV and neglect everyone else. No, but provide care for malaria, for pneumonia, and meanwhile find and treat all the patients with HIV. So after a couple of years of that public sector work, we were invited to replicate that model of a charity, an NGO, supporting the public sector to provide AIDS care in a comprehensive way to strengthen the health system. The very term health system strengthening came out of that work. And I met Sarah, I believe, in 2004. And she was telling me this terrible story, of what that was like, seeing people die. And I had seen the same in Uganda, and many of our colleagues had seen the same in other countries. And she had seen it in Lesotho, and she said, I want to go to a place where I can actually treat children. She's a pediatrician. We made her treat some adults too. And I said, well, pack your bags. So why don't you tell us a little bit about what that experience was like?
Yeah, so when I joined Partners in Health in 2005, I was just a freshly minted pediatrician, a couple weeks out of my residency, and had done a little work in other countries, but moved to Rinkwavu in Rwanda, where PIH was just starting our first project. And when you were talking about some of the patients earlier, it made me think of that patient, John, who had, that skinny man.
Yeah,
you remember him?
Yeah.
His arms were just like this, and he... we went to this rural part of Rwanda where it was more than 300,000 people without one single doctor, right?
Yeah.
No access to HIV medications. And so what we
No
found...
access to any medical care.
Right.
Yeah,
if a woman needed a C-section, she died,
Yeah.
right? And so in those early days, it was really, and you had done this before in Haiti, it was very new to me, but we were just going out into the villages and just finding people like that man John, who was just impossibly skinny, and saying, come in, we have this broken down building that we're going to make into a hospital, but we've got the medications, we've got some doctors, we've got some nurses, and we can do something. And so, just remembering that transformation of just everything from people's lives to the hospital building to the whole community to people having hope, hiring hundreds of community health workers who had been there all along, caring about their communities, but, finally had the tools to go do something about it. And as a pediatrician, for me, on the pediatric side, a lot of it was finding orphans, finding children who either had HIV or didn't have HIV, but it was too late for their parents. And so they were, in unsafe living situations and not going to school, and some of them were quite sick, and just getting those kids on meds, and then also, as I was saying, having the ability, having my job be to not just give them medicine, but to make sure they went to school and that they got healthy and that they were safe at home and that they had community health assistance. And there's nothing more gratifying as a pediatrician. And so I just feel like it's so, seeing that success is really, the only reward you really need as a doctor. But then over time, as the programs grew, and as you were mentioning, people don't just have HIV, they have lots of diseases. And I think that, as you were talking, when I hear the history of PIH again, it always makes me think about, we don't do HIV because we just love HIV so much. We do HIV care because it was this huge burden of global suffering. It was huge injustice, huge inequity. It was a disease for which we knew there was treatment that worked, and the poor people of the world weren't getting it. Mm-hmm. And so that's the same. And when we were, when you guys were doing that early treatment in Haiti and succeeding and, using that to convince people, and, the global health experts were still saying it's not practical and, it's too expensive. That's still what people say today about other things like cancer, and so those same arguments, and I think that's what PIH is still doing today is finding there's no reason a child should be dying of HIV, and there's no reason in most cases that a child should die of cancer.
Yeah.
And so that's where we need to be stepping in and fighting for those people who don't have a voice, and fighting with them and insisting that we bring that care. And so
Right.
it's not really about HIV, but
Right.
HIV, I think, has been one of the most powerful examples.
Yes,
You know?
absolutely. And Sarah and I are here, as I mentioned earlier, speaking for a much larger team, and part of the reason we have some wonderful representatives of our field work coming in future Facebook Live events. But today, our team in Haiti, our team in Sierra Leone, our teams around the world are involved in World AIDS Day events. They're very busy on a day like today. This is always a big day for us, but I want to highlight a couple of the contributions of some of our amazing staff. I mean, Fernay Leon, who worked very closely, hand in hand, shared an office, exam room for many years with Paul Farmer, was one of the architects of the HIV Equity Initiative in Haiti. And when I met him, I was also kind of freshly minted infectious disease doctor and didn't really know how to treat people without all kinds of lab tests. And he just looked at me and he said, Joya, we don't have them. And in fact, I'm glad we don't. Because at this point, we need to show that this can be done in a very unsophisticated way, so this can be an example. And he said this in 1999, this can be an example for our brothers and sisters in Africa. If we make it complicated, it will stay as a boutique, small thing. And he, in fact, went and helped in Rwanda as hiring our first staff. But there's so many of our physicians and nurses in Haiti that really led the way, and community health workers as well. Many of them living with HIV. Adeline Mersan was one of our very first patients who's still alive, still on her first regimen, started on antiretrovirals in 1998. And has trained, a huge army of community health workers, around Haiti, so we are so thankful that she's alive and a great spirit. And there's so many people like that. Another Haitian physician went and set up our program in Lesotho and Malawi. Dr. Jonas Rigadon, Dr. Pierre Paul, Frisline Shello. There were so many. Marcel Sauveur, our great pharmacist. So many people have been involved in the struggle. Maybe you want to mention some of our amazing team in Rwanda that were early adopters to this crazy mission.
Yeah, again, thinking back to those early days, I mean, I'm thinking of Nurse Peter, who's still there,
and now heads our community health work.
Yeah, exactly, and has always just been a huge champion of the community-based work and the HIV patient care, and our early nurses, the first, Manzi, who now is our director of training here in Boston, but was the nurse leading our HIV clinic in Rukira in Rwanda, and he and I worked together very closely to find those first kids with HIV and treat them. Our earlier, Modeste, who's still a great friend of PIH in the Ministry of Health now in Rwanda, was another nurse, Eric, many others of her, and Jean-Claude, our director of the head community health worker.
And Jean-Claude is someone I thought it would be nice to highlight on a day like today, and then maybe we'll move to kind of future, where we're going with HIV. But I think Jean-Claude, whose nickname is Gatoto, and is just a wonderful friend, he's the head of all of our community health workers. He's the leader of the community health workers. He, like many people living with HIV around the world, was very open about his HIV, a very brave man, a genocide survivor, lost, I think, over 20 members of his family, but such a kind person, and had basically made his house into kind of a nursing home. And I think he had 9 people sort of living in beds and cots around or in his home, and he was trying to share his small amount of food with them. And he was the leader of an AIDS organization, and many of these people knew they had AIDS. They even knew their CD4 count. They had taken their small amount of money to get a CD4 count, but there was no treatment at all. And so as soon as we came and said, this is what we want to do, I mean, he was able to say, go to this house, go to that house. I mean, he was just absolutely a community pillar, even though he himself, was living with HIV and sort of bravely spoke about that. So there were people like that, Joseph June, who whose suffering became chronicled by our colleague David Walton in a before and after picture that, with his consent, was used by the WHO to encourage people to take antiretrovirals, and he died after 13 years of a very fulfilling life on antiretrovirals, saw his kids go to school and became a community educator. So, there are many people whose lives were prolonged, were improved. But, we have work to do. So there's this great success of, 17 million people around the world, all getting antiretrovirals, most of whom have free drugs, free tests. But there are many struggles. These are often poor and marginalized people still who need a lot more support. The health systems continue to be weak and fragile and need many more investments. But we also think we are at a tipping point to really change the trajectory even further on the epidemic. We just heard our statistics in Haiti, which are remarkable, from Dr. Patrick Almazor, our chief medical officer, this morning, that Haiti has halved its HIV rate in the last decade, which is just amazing. But we know we can go to zero. We can get to an AIDS-free generation, and that's the work that Sarah has been really leading at Partners in Health globally. So maybe, Sarah, you can tell us a little bit about what we're doing to get to that AIDS-free generation.
Yeah, and of course it's very much part of the whole global movement, and that was really the theme of this year's International AIDS Society Conference, how we can reach the goals of what are talked about as the 90-90-90 goals, in terms of getting 90% of people with HIV tested to know their status, getting 90% of people with HIV on antiretroviral medication, and then of the people on meds, getting 90% of those to have their viral load suppressed, meaning that they're taking effective treatment and they're staying healthy. So,
and they won't transmit,
and they
likely
will
not
exactly,
transmit
right.
to others. Yeah.
And I think that's a really key thing where, in the past people have really talked about treatment versus prevention. I think it's just abundantly clear now that treatment is prevention.
Mm-hmm.
And so that if we have people living chronically, on effective medications with HIV, they're not going to give HIV to other people. So, as with many people in the world right now, we are working towards those goals, and I think we've made incredible progress at some of our sites with the highest burdens, like Malawi and Lesotho, even in just the last couple of years. Our program in Haiti has just had a huge push to find all those patients that need to be found and both diagnosed and put on meds, and so we're getting closer. I would say that our approach in trying to do this is in some ways the same thing we've always done, right? Mm-hmm. It's just using this community-based approach, solidarity, community health workers to help us find patients and link them to care and stand with them, going to the most rural places, finding the places where people don't have access to meds. And I think as we kind of get closer and closer to that 100%, it's going to be more important to have more specific strategies for the people who are somehow being left, falling between the cracks, right? And so I think of groups like adolescents, for example, and especially adolescent girls. I think that, we know that while we're making all this global progress, that adolescents are actually, there's increasing rates of new infections. Adolescents have the lowest rate of knowing their status of any age group. And so we can't just kind of think of HIV as just a block. We have to really develop specific strategies. So what is it we can do? What are the barriers for adolescents? What would it take to actually get them into clinic and keep them on treatment? You've got an incredible amount of just stuff going on when you're an adolescent, and then you've got HIV on top of it. I think the only way we're going to be successful with that is again addressing the gender and the power dynamics and giving girls power and agency over their lives, their education, their sexuality. And so we've got to have strategies that are tailored to those challenges. I would say another key group would be just, eliminating mother-to-child transmission, because we know how to do it. We don't see children born with HIV in America. We're still seeing it all over Africa. And we've got to make that access universal. And then just kind of any group that's still being marginalized and having economic, social, and other barriers.
And
to
political.
treatment.
We know that, for around the world, men who have sex with men
right.
and other
yep.
people who might be at high risk, whether it's commercial sex workers, intravenous drug users, some of the political pressure, which is not around acceptance or help or support, but is punitive, drives people further underground and further away from medical care. So that's continues to be important in many countries around the world, and even here, as we see policies being implemented against Planned Parenthood, against these are really important. And then you want to talk a little bit about PrEP and what it is and why it's a new tool and how we might think about using it.
Yeah, so PrEP is pre-exposure prophylaxis, and it's there's been different regimens, but for example, a daily pill that someone might take who does not have HIV, who might be at high risk. So, for example, discordant couples. A sex worker, or an adolescent, or especially an adolescent girl who might not get to make all the decisions about when she has sex. So, there's been a lot of recent studies showing its effectiveness in preventing HIV. So it's a medication, if you're taking it regularly, and then you have this exposure where you may be getting exposed through sex to, or through drug use or whatever, to HIV, can actually prevent infection. And so, ministries of health in Africa are now looking at some of those things, and actually some have already incorporated it into national protocols for certain high-risk populations. And I think that's going to be another key way that we can take very specific risk groups and do something that's going to prevent them from getting infected. So I think that's one of the most exciting things happening right now globally. But as with everything, it's accessible to wealthier people and not yet to poor people.
Right, and the people it's not accessible are higher risk. I think, maybe just to wrap up by saying that, it is not over. We have, if we want to meet these goals Sarah was talking about, we need a lot more money. We need a lot more money globally for AIDS treatment. There's a sense that it's over, things are ratcheting down. That cannot happen. This is when we need more money, more focus. We can eliminate HIV from the next generation. It's a very exciting thing. Disease eradication is something we often only dream about. And I've been recently sort of reviewing some of the history. When you saw this slow ticking clock of exponential growth of HIV with the world just watching, we could watch it go the other way, but countries aren't adopting PrEP because of lack of funds. They're not adopting special tailored programs for vulnerable groups because of lack of funds. And so we really need activists and people who care about this to take up the mantle that the activists really helped us to understand, that when we fight together, we can win. When we make noise about something, we can really change the trajectory of history. This is not a technical fix. This is a fix of solidarity, of sticking with it. It's a fix of sort of money and support. We've got the technical know-how, but getting that broadly out there really takes a lot more support. So we appreciate everyone tuning in today and listening to these kind of interesting sort of historical and future ideas we have for HIV at PIH. And it's an honor to represent our huge HIV team around the world. And we're sorry we don't have Dr. Hind Sati, another Deputy Chief Medical Officer. She's stuck in transit between Africa and Boston today. So I want to thank everyone. And Sarah.
Yeah. Thanks, Joy, and thanks everyone. We're ready to keep fighting.
Yep. Happy World AIDS Day.